ever been examining a newborn baby? And when you go to examine the lumbosacral area, so kind of the lower back or the upper buttocks, you see some sort of weird dimple at the bottom of the back. Obviously, this one's massive, but some sort of weird dimple or a hairy patch or an abnormal birthmark, and you wonder whether it signifies anything and whether you should be investigating it further. Well, if you have, then this is the video for you. Hello, I'm Dr. Tala, and I've been a neonatologist for 17 years now, and I've often faced this dilemma. Should I be doing something about that dimple? Should I be doing anything about that weird hemangioma over the spine? So today we're going to be talking about occult spinal dysraphisms and their cutaneous stigmata. That's a sentence I'll explain in a little bit. Before we start, if you are interested in becoming a member of our lovely neonatal community and helping us choose which videos that we're going to film next, then please join us, and all the details are below. Right, so today we are going to be covering what is a neural tube dysraphism and when is it considered occult. 2, some embryology. I promise you this is going to be quick and painless. 3, why should we be concerned about dysraphisms? 4, what should you be looking for in physical exam? And 5, which ones are considered high risk and we probably should be doing something about them. 1, what is a spinal dysraphism? We also use the term neural tube defect pretty much interchangeably, but basically it means that something has gone wrong with the neural tube, so generally involving either the spinal cord or the nerve roots. There is a wide spectrum of congenital abnormalities that can occur as a result of abnormal formation of the craniospinal axis. So there can be abnormalities anywhere down from the brain all the way down to the nerve roots. This can occur in isolation, so like it's just a myelomeningocele, or it can occur as part of a syndrome or a genetic issue. Lots of different ways have been suggested to actually classify these spinal dysraphisms, but basically we put them into 2 main groups. The first group is if there is actually an open defect. So you have actual exposure of neural tissue and you can actually kind of see bits of the spinal cord or the nerve roots outside the body. Or it could be closed, where you have skin, even if there is some sort of abnormality on the skin, actually covering the neural tube defect underneath. Obviously, if the defect is open and you can actually see bright red neural tissue hang out, like in a myelomeningocele, then immediately you know that you have a problem. But sometimes when it's closed, you can't figure out if there really is something going on underneath. In this case, it may be a hidden spinal dysraphism, or what we call an occult spinal dysraphism. But just because we can't see them, it doesn't mean that these occult spinal dysraphisms are innocent. Either they could represent an abnormality in the formation of the spinal cord, or probably more commonly, it results in putting pressure or traction on the spinal cord or the nerve roots and ending up with something that we call a tethered cord. Examples of this include a lumbosacral lipoma, where you can have like a little ball of fat extending into the spinal contents and the nerve roots or the spinal cord may be attached to it. Or a diastometomyelia, first time I've ever said that word out loud, which is a congenital condition where part of the spinal cord is literally split, normally in a sagittal or a longitudinal direction, normally at the level of the upper lumbar vertebrae. Also, you could have transverse ligamentous bands, or cysts, or dermoids, or hamartomas, or just an abnormality of the spinal cord itself. So lots of various abnormalities could be hidden in that kind of spinal contents. Often, these occult defects in the neural system may have some markers on the skin. That's where these dimples and the birthmarks come into place. It may be signaling to us that there's something going on underneath. And the reason for that is all in the embryology. This brings us to part 2, which is what is the underlying embryology. So the spinal cord develops very early, somewhere between weeks 3 and 5 of gestation. Honestly, a lot of times before mothers even know that they're pregnant. If you just had to study for your boards, then you'll definitely remember the various stages of neural tube development, gastrulation and primary and secondary neurulation. I'm definitely not going to be covering those here today. Remember though that the whole baby is made out of 3 germ cell layers: the ectoderm, the mesoderm, and the endoderm. And what you do need to remember and understand is that the skin and the neural tissue were both ectodermal in origin, and they separate from each other, the skin and the neural tissue, very early on in gestation, about the time that the neural tube is closing. So this embryologic origin of the cutaneous ectoderm and the neural tissue very early in gestation explains why, if there are abnormalities in the nervous system, there are very often abnormalities of the overlying skin. Which honestly is kind of lucky, because at least it gives us clues about what might be going on in the spine and the nerve roots. 3. Why should we worry about these occult spinal dysraphisms? Well, as you can imagine, we want to catch them early, because early identification and intervention of these spinal dysraphisms may prevent irreversible neurological damage from the tethered cord syndrome. Patients may also have anorectal or urogenital abnormalities, because those structures arise from the cloaca, a common cloaca that is located right next to the distal portion of the developing neural tube. Tethered cord syndrome is a constellation of neurologic, orthopedic, as well as urologic abnormalities. So problems in feeling and moving, problems in your bones and muscles, as well as potential problems with urinating and stooling. All of those can happen from tethered cord syndrome, and it can result as a consequence of many of the different types of spinal dysraphisms. Just a little bit more anatomy. So normally the conus medullaris, which is the last portion of the spinal cord, normally it hangs freely, but it's stabilized by an elastic band called the filum terminale. During embryogenesis, the spinal cord grows at a lower rate than the rest of the spinal column and the vertebrae. So relatively, as the baby gets older, the spinal cord is relatively higher up the back. That's why when we're doing a tap in babies born at a very early gestational age, we want to go lower, because the spinal cord itself will be lower at that point. Between about birth and 2 months of age, the conus medullaris, which is the lowest portion of the spinal cord, or where it ends, will be at the level of L2. So the second lumbar vertebrae, which is the same level of adults, in about 98% of the population. Usually that cord is free to move around a bit, and as the patient grows, obviously it needs to grow too. But if the lower end of that cord, or the nerve roots, or the filum are actually stuck to something, then obviously that cord is going to be tethered or stuck, which will result in increasing ischemia as well as mechanical traction or pressure on the cord. If left untreated, a tethered cord can result in progressive neurological damage. So loss of function of muscle control in the legs, loss of bowel and bladder control. You can end up with scoliosis and severe back pain. And if it goes on too long, you can even end up with paralysis as the body grows and there is irreversible damage done to the spinal cord. Essentially, symptoms will carry on worsening until they are addressed, and hopefully some sort of intervention is done before the symptoms become permanent. Treatment obviously would be neurosurgical intervention, where the cord is untethered, not like that obviously, but you know what I mean, untethered, and they also have to take care of whatever anatomy was causing the tethering in the first place. A big part of testing and treating of a tethered cord is also urodynamic testing. So doing whatever we can to make sure that the bladder and the bowel are going to function as adequately as possible. So if a baby does have an occult spinal dysraphism, then it would be great to know about it as soon as possible to make sure that we can prevent any permanent damage of neurological symptoms. 4. What should we be looking for on physical exam? Well, this is where it gets a bit complicated because it's estimated that between 4.2 to 7.2% of all newborns can have some sort of skin markings that may be considered concerning for an occult spinal dysraphism. But it's also been reported that between 50 to 80%, more likely on the upper end of that, of babies with occult spinal dysraphisms have cutaneous markings. So that's good that we pretty much most often have a clue to something going on with a neural tube underneath. Most of these lesions are found on or near the midline. It doesn't have to be right in the middle of the back though. And most of them are in the lumbosacral area. But even if they are in the thoracic or cervical areas, that could still indicate an underlying abnormality in the spinal cord. The skin markings are completely varied. You could have, for example, a mass. So for example, a lipoma, which would be a soft fatty mass, kind of like causing a bump in the skin. So generally they're found in the dermis. And often these lipomas will be connected through the intervertebral space into the spinal canal. Lipomas are a very common cause of a tethered cord. Another mass could be a dermoid cyst, which is more of a nodule. It's a bluish tinted nodule, which is non-compressible. Or it could be like an acrocordon or a skin tag, which as you all know is like that small kind of pedunculated little flesh-colored tag coming out from the back. Sometimes these really are the vestigial tails in babies. So just kind of like little growths that shouldn't be there. Or the marking could be more of a birthmark, or for example, an infantile hemangioma, which is kind of similar to the strawberry hemangiomas that we see. And depending on the size of the hemangiomas, it puts the baby at a higher risk of having an OSD or not. And we'll talk about that in a second. A port wine stain or telangiectasia type of lesion could also be seen. These are generally blanching lesions. And this is also a really important point because generally if the lesion is blanching, then it puts the baby at a lower risk of having an occult neural tube defect. The birthmark could also be kind of an absence of skin, like a cutis aplasia, or it could be a congenital scar, which kind of looks like the cigarette marks. Both of these are concerning for an OSD. Or the birthmarks could just be areas of hyper or hypopigmentation. Hypertrichosis, or a hairy patch in the lumbosacral area, is something else that we look for because it can also be concerning. Remember though, that having hairy patches in the lower back can be very typical in many different types of ethnicities. So this type of hairy patch is kind of different. Here, the hairy patch is often V-shaped at the bottom of the back, and the hairs themselves have been described as silky or fawn-like, and they can be much longer than you would expect. So that's when you would find that hypertrichosis more concerning. And then, of course, all the dimples or the pits that we see. Depending on the size of these dimples and the position of them, that puts them at higher or lower risk for these babies actually having an occult spinal dysraphism. Most infants with sacral dimples that fall within the gluteal crease are healthy. What makes the sacral dimples more concerning is if they are large, so above 0.5 centimeters. So this one's definitely above 0.5 centimeters. And depending on how far away it is from the anal verge. So if it's more than 2.5 centimeters away from the anus, that's also concerning. So as you can imagine, this would be a very concerning sacral dimple. Also, if those pits are associated with any other cutaneous markers, and we'll talk about that in a second, then again, that puts them at much higher risk. Another important thing that you need to make sure you're not missing is a dermal sinus. So that is where there is connection from the dermis all the way down into the spinal contents through the intervertebral spaces. Those are the cases where you literally cannot see the bottom of the pit. That's when we worry about those. So try to figure out exactly how deep that pit is going. Often, if there is a dermal sinus, then you'll see kind of yellowish fluid emerge, or maybe even like a tuft of hair come out. Obviously very concerning. So in addition to examining the whole back and head, and obviously your full physical exam, make sure that you do a really good exam of the genital and the rectal area, because that could be associated with other congenital abnormalities in those areas too. A gluteal cleft that deviates, so instead of kind of going up the middle of the back, it's kind of going off to one side, is also very concerning, that there could be some sort of underlying mass, like a lipoma or something. So always make sure that that gluteal cleft is completely symmetrical. In babies, even if they did have a tethered cord, it's very unlikely that they would have any effects on their muscles or their lower extremities immediately after birth. But in older children, obviously this is a very important part of the exam, making sure that there is good muscle strength and movement in the legs, as well as normal back, no scoliosis and everything. 5. Which skin lesions puts babies at higher risk of having occult spinal dysraphisms? Okay, so you've done a really good physical exam, you've looked at the back and everything else in the urogenital area, and now you have to decide, should you get further imaging or should you even refer to neurosurgery? How do you decide that? Well, the first thing that you should know is in a meta-analysis that was published in 2020 by Choi et al., it showed that even if you do have skin markings that are traditionally considered concerning for a spinal dysraphism, the chance of truly having an occult spinal dysraphism are really low. In their meta-analysis, where they included all the babies that were studied with cutaneous stigmata, so abnormal skin findings that could be suggestive, if they included all the babies in all the groups, so high risk as well as low risk lesions, and I'll talk about that in a second, then if you had a cutaneous stigmata, the chance of actually having an occult spinal dysraphism, so something concerning for a tethered cord, is about 2.8%. And out of all those babies, the number that actually needed neurosurgery was 0.6%. So really very low numbers, even with abnormal skin findings. If a baby had 2 markings, so for example, a dimple as well as a birthmark somewhere, then the chance of the baby having an OSD jumps up significantly to actually 10.5%. Another really important differentiation, and I would say this is the take-home message of the entire video, is the difference in percentages of a baby having an OSD if that baby has a simple dimple versus an atypical dimple, which is why it's so important for you to be able to recognize which is which. If a baby has a simple dimple, the chances of the baby having an OSD is 0.6%. If that sacral dimple is atypical, and again, we'll talk about that in a second, the chance of the baby having an OSD is 8.8%. So we really need to be able to differentiate those two. So what should we consider high risk, intermediate risk, or low risk? And what should we be doing about those? Well, luckily, in a review by Sewell et al., they published a table pretty much telling us exactly what to do. And I'll kind of go over that now. Let's start with a high-risk group. So a baby would be considered high risk for having an OSD if, as we said, the baby had 2 or more stigmata. So for example, the baby has a dimple and a birthmark. Other high-risk things to look for are a lipoma, an acrocordon, or like we said, the skin tag, or even like a proper pseudotail, cutis aplasia, dermoid cysts, or a dermoid sinus, so you actually see kind of the yellow stuff draining out from the back, as well as an infantile hemangioma, if that hemangioma is more than 2.5 centimeters in diameter. So if you see any of these on exam, then the authors recommend that you go straight for an MRI, because these are very high risk lesions. There's a high chance that you're going to find something. And in these cases, an MRI would be more cost effective instead of doing the ultrasound and then probably having to do the MRI afterwards. The intermediate group includes infantile hemangiomas that are less than 2.5 centimeters in diameter. Also, areas of hypertrichosis, or like hairy patches, are considered like an intermediate risk. Remember, this isn't like the normal hairy patches that a lot of babies have, but it's that thinner, wispier, longer, more silky hair that babies may have, normally in kind of like the V-shaped patch. Atypical dimples are also considered intermediate risk. Again, it is considered an atypical dimple if it's larger than 5 millimeters or half a centimeter, or it's more than 2.5 centimeters away from the anus. For these babies, the intermediate risk, you could either go straight to an MRI or you could go ahead and get an ultrasound. The authors kind of left it up for the institution that's involved and really how worried you are that there could be something underlying. And then the low risk group is when we see areas of hypo or hyperpigmentation, port wine stains and telangiectasias. So again, if you see it blanching, then it's more reassuring. And if you have simple dimples, then again, very low risk of the baby having an occult spinal dysraphism. Again, a simple dimple is when the dimple is less than 0.5 centimeters, so less than 5 millimeters, and less than 2.5 centimeters away from the anal verge. So often these dimples are actually in the gluteal cleft. You should also be checking the depth of these dimples. So if the dimple is above the gluteal cleft, so more than 2.5 centimeters away, and you can't see the base, then you are really worried about that being a dermal sinus. It would be very, very unlikely to have a dimple within the gluteal cleft that's actually connected to the spinal cord. So we'd worry about that base a lot more the further away it is from the anus. For all these low risk lesions, then we don't have to do any imaging. You just send them off to the pediatrician and let the pediatrician follow them. Does that mean that there's 0% chance of them having an OSD? No, it doesn't. But the percentages are low enough that we can't afford to scan every single person looking for an OSD. Otherwise, we should just be scanning every single baby, whether they have a cutaneous stigmata or not. Ultimately, the definitive diagnosis of a baby with a spinal dysraphism is actually made during neurosurgery. All babies, before they undergo neurosurgery, should be getting an MRI. That's why in the high-risk groups, we're like, just go straight to the MRI. It's not even worth doing an ultrasound. Ultrasounds can be done in babies that are less than 6 months old before those bones kind of ossify in the back. And one last quick word about ultrasounds that kind of came up a lot in the literature. It's concerning when we actually get an ultrasound, and I'm sure you've all seen this in your units, when you're like, is there a tethered cord or a spinal cord abnormality? And they come back and they'll be like, there isn't anything obvious, but the conus medullaris is a bit lower than it should be, or the filum terminale is a little bit thicker than it should be. A low-lying cord would be considered like L2, L3, that sort of intervertebral space or lower. And a thickened filum terminale is considered thickened when it's more than 2 millimeters. Again, nobody's really sure what to do about these. We're definitely not going to go ahead and do surgery. What you're really looking for on those initial ultrasounds that you may be getting for the intermediate and high risk groups, or high risk if you're not going straight to MRI, is whether there is some sort of mass or some sort of gross abnormality that you need to do something about immediately. So yes, even those ultrasound readings can be really, really tricky. All right, that was it. I hope that you all learned something and that it will help you kind of take care of the babies and decide when to get ultrasounds or not. I know that we're all getting a lot fewer ultrasounds than we did like 10 years ago as more of these reviews and meta-analyses came out. If you reached this far, please like this video and subscribe to our channel if you're interested in neonatal education. We'd love you to join our membership as well so you can help us choose which videos we're going to have next. Thank you so much for being here.